we come to patient adherence, a major barrier to treatment success. But we must understand the drivers of adherence. One, we have done through Oriax and my previous life, we have done studies across more than 46 countries of the world on the drivers of adherence. And we have found that forgetfulness is not a driver of poor adherence. A person who is supposed to take some medicines regularly may forget once to take that medicine, or may forget it. So he's supposed to take it in the morning, he takes it in the evening. But he or she does not sustainably forget to take the medicine. Poor adherence is a conscious and to the patient a rational choice made. This patient is not forgetting, and therefore sending SMS reminders actually has very little impact on the adherence of these patients. The drivers of adherence that we have seen are what I call the 3 C's. The first C is cost. Economic cost versus lifestyle cost. In tuberculosis, for those who cannot afford, TB treatment is free. So it is not an economic cost, but there is a lifestyle cost because one has to change one's lifestyle. And in situations of poverty or substance abuse, these lifestyle changes are often very difficult to perform by these patients. The second is a concern that am I getting the right treatment? Concern for lack of efficacy because symptoms are continuing. Concern for side effects. Somebody gets nausea, vomiting as a consequence of one of the drugs, maybe pyrazinamide or ethambutol, and thus making the quality of life of this patient poor. And because of this reason, this patient, or he gets joint pains because of elevated uric acid, and all of these result in the patient saying, look, I don't think I want to continue with this treatment anymore. And he may not come back to the doctor and tell him, I don't want to continue this treatment. He may simply drop out. The third is there is a fear that there is nothing happening to the core disease. And this often happens because there is a lack of well-being in the initial phase of treatment, that some patients do not feel that well-being that they were anticipating as a consequence of that treatment. And the final C is a commitment to one's health. This is seen lacking in many TB patients, either due to poverty, and the doctor tells them that you must take this food or this medicine or this additional vitamins or this or that, and the person thinks, I'd rather get my child a glass of milk than spend money on this. Additionally, people who are in substance abuse, alcoholism, or drug abuse, such people typically would rather spend money on those kinds of things rather than treat their tuberculosis effectively. What is therefore required, along with very effective treatment, one requires counseling to give the best chance for the adherent patients. And data shows that in the population, there are about 20% of people who will adhere whether you say anything to them or not. There are another 20% of people who will not adhere whether you say anything to them or not. But the 60% of people who do not adhere if you do not say something to them, but adhere if you say something to them, are the ones whom we can, as a medical fraternity, truly influence. And through this mechanism, we should be in a position to significantly enhance treatment. Because of a perfect diagnosis, we will create a scenario that the patient gets a sense of well-being, and because of that, he or she is motivated to continue treatment and thus reach a level of cure. So in other words, there is a medical problem and there is a management problem. The medical problem is that with highly effective drugs, why are we not able to get the right drug to the right patient at the right time? This is because there are many stakeholders in the management of tuberculosis. And each one of those stakeholders views the problem somewhat differently. And none of them probably has the full picture of what it takes in order to, get on top of this problem of tuberculosis. We have to get the right drug through overcoming a diagnostic delay. That we today go through an iterative process where we test once and then we test again and then we test a third time in order to try and reach exactly what is the resistance pattern of that particular bacillus in that particular patient. This results in a major loss to follow-up, because when one goes through such iterative processes, patients typically drop out of treatment. The second is our inability to look at different subpopulations differently. And we need to understand different subpopulations of patients from a disease and a psychosocial perspective. And finally, to be able to get the right drugs fast enough so that the patient doesn't lose heart and is lost to follow-up. So what are the important subpopulations of patients? So if we look at fresh cases versus retreatment patients, but within these RIFA-sensitive population, there are about 5% of patients who show resistance to other drugs, either isoniazid or pyrazinamide or ethambutol. In these cases, general condition of patients determine the urgency of treatment. Then we come to immunocompromised patients who are either HIV positive or diabetic. And we discussed what is the impact of this immune compromised patients, not just the HIV, which may not be such a big problem in this country, but diabetes is a major comorbidity in TB patients. The high incidence of recurrence due to low-level resistance and multiple strains is a major challenge for which we need good diagnostics. Through a line probe assay, get a case which is but low-level resistance where the cells are actually throwing out the INH more rapidly becomes very difficult, and these can occur even in RIFA-sensitive patients, and we need to watch out for that. Then there are fluoroquinolone resistance. In this country, because of the widespread, and I may even call it overuse of fluoroquinolones in general patients for respiratory or urinary tract infections, fluoroquinolone resistance is common in virtually every subpopulation of patients. In situations that each clinician managing tuberculosis faces, that is a RIFA-resistant case, because it is the pivotal drug of this regimen, and these require a thorough evaluation of the resistant status, because we may be missing MDR-TB or XDR-TB, which is resistance to both INH and rifampicin, or XDR, which is resistant to INH and rifampicin and a fluoroquinolone. Now we see about 5 to 10% of MDR-TB in fresh cases, with 35 to 45% in retreatment cases. And XDR-TB, we see 1 to 3% in fresh cases, 30% in retreatment. Current treatment paradigm, if you see, is a patient comes in, we go through gene expert, and determine whether the patient is RIFA resistant or RIFA sensitive. If the patient is RIFA sensitive, we start the patient on our first line drugs, EHRZ, HRE. If the patient is resistant, we take him through a line probe assay to see whether is INH sensitive or resistant. If the patient is INH resistant, we request for a culture and drug susceptibility test, where 15 to 16 antibiotics sensitivity profile is done. But whereas a gene expert gives you the result in a few hours, a line probe assay may take between 1 and 3 days, depending on whether you require first line probe assay or a second line probe assay. Therefore, final answer, if necessary, it comes to us only within 3 to 6 weeks and costs as much as 15,000 rupees. Whole genome sequencing is bringing the accuracy of genomic technology to TB treatment, which is providing resistance or sensitive information for the bacillus for 18 antibiotics. And how does this work? It works that a patient delivers a patient sample, and depending upon severity, if the patient is smear positive, 2+ or 3+, one can probably reduce the time of that we need until we can get a good DNA extraction. If the patient is 1+ or less, or a bronchoalveolar lavage fluid or something of that nature, it may need to be enriched before we do a DNA extraction, which takes about 4 to 5 days. From the DNA extraction, depending upon load, it may take 1 to 6 days. And then we go through a sequencing process, the analytics report. What does this mean in terms of turnaround time? It means today a report will come back in 8 to 12 days. But in a few months' time, in 2 to 3 months' time, hopefully this number will come down to 3 to 4 days. In a year's time, possibly even the same day on-site results will be available. And the cost of this test is just rupees 3,000, which is just a margin higher than the gene expert tests that one is. This is, as a consequence of this, how do I see the prioritization of patients for whole genome sequencing? I see this as those who have XDR TB, which are RIFA resistant on gene expert, INH and fluoroquinone resistant on LPAs. Such patients must necessarily have a whole genome sequence done. MDR TB patients, RIFA resistant on gene expert, INH resistant on LPA, because of the background resistance to fluoroquinolones, it would be advisable to take these patients for whole genome. Patients on gene expert would be good if the patient's general condition is poor and therefore there is urgency and need to start correct treatment. If the patient is otherwise healthy, one may even wait a little while. But if the patient is not otherwise healthy, as most are not, a RIFA resistant patient, it may be advisable to get a whole genome sequence done so that one is providing accurate treatment to the patient. And finally, to immunocompromised patients, those who are HIV positive or diabetics, regardless of gene expert results, these whole genome sequencing should definitely be done. We will reduce the chances of spreading of infection and thus be able to rapidly eliminate TB from India.